everyone, and welcome to today's webinar. My name is Dina Jones, and I'm the Director of Professional and Public Relations here for the American Association of Christian Counselors.
And I'm Lindsay Groots, Special Projects Coordinator for the AACC.
Today we have Dr. Linda Mintle and Dr. David Jenkins joining us on the opioid epidemic, a Christian counseling response. And we're broadcasting today live from our national headquarters in Forest, Virginia.
We are thrilled to welcome you to today's webinar. We have a great one in store, and it's always a privilege to share this time with everyone from who's viewing all over the world. Today's topic is a sobering one, but we are encouraged by the response that we've gotten from our viewers and our members, as well as the expertise of our presenters today.
Webinar days are always my favorite days here at the AACC. We do this every single month. We bring in national experts on different topics that will help you as a clinician, as a lay counselor, as a pastor, to best serve the people that you care for every day. Our webinars are already a great value at only $20, but I also wanted to bring your attention to the fact that if you join the AACC and become an AACC member, you will get 12 webinars a year for free as part of your membership, and you will also get conference discounts, a quarterly magazine, a monthly e-news, as well as several audio and video resources, including, like I said, the 12 webinars, just for the cost of 4 or 5 webinars. So it's a wonderful value. We love our members, and we hope that you will join us. Some of our upcoming webinars that we hope to see you with will include topics such as substance abuse, eating disorders, narcissism, and more.
And before we begin today, we just want to take a couple minutes to go over some logistics. Our webinar today is going to be about 2 hours in length with one time for Q&A at the end. So you'll see in the bottom right-hand corner of your screen a button where you can submit your questions. Make sure you do that early so we can have plenty of questions for our experts. And if you are planning to get continuing education credits, do make sure that you follow the instructions on your screen so that you can make sure to get your CE letter. And before we begin, let's take some time to pray together. Lord, we're thankful that you're with us here today. We're thankful that you love us, and we just ask that you'd open our minds and our hearts to what our friends are going to be sharing with us today on this very important and very relevant topic. Lord, we just ask that you give us the wisdom and the courage to know how to best help others that we know that are affected, and we thank you for the grace that you give to us so that we can extend it to others as well, Lord. We pray that you would just speak through our presenters today, God. We thank you for the knowledge and the understanding and the experience you've given them, and we pray that we would just get a lot out of our time together today. And we pray these things in your name. Amen.
Amen. Well, it's now my privilege to introduce Dr. Linda Mintle, and when we say we bring the best in for our webinars, we bring the best in for our webinars. Dr. Mintle is the chair of behavioral health at Liberty University's College of Osteopathic Medicine. She received her PhD in urban health and clinical psychology from ODU, a master's degree in social work, and a Bachelor of Arts in psychology and communications from Western Michigan University. She's a licensed marriage and family therapist. She's a licensed clinical social worker. She's a national speaker, a best-selling author with 19 book titles currently published, and she has numerous articles and textbook chapters that she's authored. She's the host of the Dr. Linda Mintle radio show. Check that out on Faith Radio. She's a national conference speaker who just always does such an incredible job at the AACC conferences and more. She's a national blogger for BeliefNet, and she appears regularly as a national news consultant for various networks on issues related to mental health.
And it's now my privilege to welcome Dr. David Jenkins. Dr. Jenkins is a professor of counseling and the director of the MA in Addiction Counseling program at Liberty University, and he teaches in the Department of Counselor Education and Family Studies. And he previously served as the clinical director of the International Board of Christian Counselors for the American Association of Christian Counselors, and is currently on the executive board of the Society for Christian Psychology. He has more than 25 years of clinical experience, and he specializes in the integration of Christian faith and clinical practice. He has worked extensively with mood, anxiety, and addictive disorders in the context of individual, marital, and family therapy, and he has provided education, consultation, supervision, and training for a variety of churches, ministries, and professionals. He is also an author and speaker at conferences, seminars, and retreats. So join me in welcoming Dr. David Jenkins and Dr. Linda Mental.
Welcome, glad you're here. There's probably no more timely topic than the one we're talking about today. I really believe that God has placed this challenge in front of the church, and we have the opportunity to deal with this crisis of opioids and their use and misuse and addiction to them, and we have a chance to really step up and shine, and just pray that our time today will be a benefit to you. I want to start off looking at different types of opioids. We'll look at some current stats and kind of set the context for the scope of the problem. Some types of opioids, opioid medications that can be used licitly, in other words, according to prescription, or illicitly. Prescribed medications used non-medically, not according to prescription. Some of the ones, old school, codeine, of course, morphine, hydrocodone, or some of the newer ones, hydrocodone, acetaminophen, oxycodone. Very common pain medications now, unfortunately, too common, and we'll talk about that as we go through. Others, oxycodone and acetaminophen, combination meds there. Oxycodone and naloxone, hydromorphone, meperidine, Demerol, and then methadone. Some of the synthetic opioids, which is where some of the recent major concerns are coming from, particularly with the overdose death rates, is fentanyl and its analogs, particularly carfentanil. Fentanyl was by prescription primarily for anesthesia, post-surgical pain, and management of pain in opioid-tolerant patients. Fentanyl is 80 times more potent than morphine. Carfentanil is 10,000 times more potent than morphine. Other analogs, derivatives of these, are also more potent. It's the illicitly manufactured versions responsible for tripling the synthetic opioid deaths from 2013, where there were 3,105 deaths related to the synthetic opioids. It doesn't include all opioids, just synthetic opioids. And then in a 2-year span of time, it tripled, so that by 2015, you had over 9,500 synthetic opioid related deaths. Unfortunately, that's not slowing down, and manufacturing from overseas, particularly China, and availability online are really, the availability is really causing some troubles there. When we look at various statistics, we're going to look at numbers of prescriptions, numbers of hospital visits, number of overdose deaths, and number of number of folks struggling with opioid use disorder, mild, moderate, severe, according to the recent DSM-5 changes in the substance-related and addictive disorders scheme. So number of prescriptions. Number of prescriptions for opioid medications quadrupled from 1999 to 2010, yet there was no increase in the amount of pain that Americans reported. We're using mainly United States data in these stats. What has gone along is with the quadrupling of this, of the number of prescriptions with no increase in pain, the overdose deaths from opioids and opioid-related treatment admissions have paralleled this increase, so those have quadrupled. In the context of this, primary care providers account for half of the increase. So as they became more available, it became more of a norm to manage non-cancer pain with the opioid medications. Primary care physicians began prescribing more and more, so that represents half of this increase. Some reasons for the increase. Treatment of chronic non-cancer pain became needed. The medications, we need to be careful not to completely demonize them. It can be helpful. Some patients need it and respond, but that treatment of non-cancer pain increased the average length of time that opioids were prescribed. So if you increase the length of time, you increase the availability, and it leads to higher dosages and higher amounts per prescription, numbers of refills, things like that. So one of the other factors that is driving a lot of this opioid crisis is just the availability and having so many of the pills laying around that other people who aren't prescribed them can get to them. And so it's the non-prescribed use that's driving a lot of the epidemic, as well as a number of pain managed patients. So number of prescriptions. In 2016, the number of opioid prescriptions was close to 215 million prescriptions. That represents 62 million, almost 62 million patients. That's almost one prescription per adult in the United States. The average number of opioid prescriptions was 3.5 per patient in 2016. So you've got a number of people using multiple medications. Annual prescribing rates in 2016, greater than or equal to a 30-day supply, was 27.3 per 100 persons. So again, that's looking at the length of time of supply of the meds around. And that's one of the numbers that needs to get tracked, along with how many were under 30 days supply, and that was 39.2. That number of less than 30 days supply ought to start dropping pretty dramatically, and I think there's already some movement in that direction. There was a 64% increase in hospital visits between 2005 and 2014 in opioid-related inpatient hospitalizations, 99% increase in emergency department visits, 90 people per day in 2014 rates died from opioid-related overdoses. Over 130 per day based on 2016 rates. So that's a 45% increase in opioid-related overdose deaths. So you've got total overdose deaths, and then you've got the opioid factor in that. About 75% of all overdose deaths are opioid-related, and that represents a 45% increase in 2 years. 4 in 5, looking at the American Society of Addiction Medicine data, 4 in 5 new heroin users started out misusing prescription painkillers. 94% of respondents in a 2014 survey of people in treatment for opioid addiction chose to use heroin because prescription opioids were far more expensive and harder to obtain. So heroin became the more available, cheaper alternative. And so one of the things we have to watch out for as supply side tightens up on things, prescribing practices, things like that, we have to watch out for finding quicker and cheaper, more accessible routes like heroin. So we have to do something on the demand side. The number of folks struggling with opioid use disorder, mild, moderate, or severe. Roughly 21 to 29% of patients prescribed opioids for chronic pain misuse them. So somewhere 21 to 29 of people being prescribed chronic pain percent misuse those, approximately 15.2 million folks. Between 8 and 12% develop an opioid use disorder. An estimated 4 to 6% who misuse prescription opioids transition to heroin. And about 80% of people who used heroin first misused prescription opioids. So the SAMHSA, the Substance Abuse Mental Health Services Administration, in 2017, so this is current data, estimate 2.1 million people with opioid use disorder. Again, mild, moderate, and severe. So a couple of diagrams there. You've got to think about not everyone who misuses moves on to addiction. You can have use disorder without full addiction, but that's certainly the pathway. And this graphic touches on that. Let's see. Yeah, that's mainly just getting at rates of misuse and who's misusing what. That next slide, that figure 32, and that's from SAMHSA documents. The number of people in thousands that have any pain reliever misuse is represented in the left-hand side, and on the right-hand side, you have the percentage of people that represents age 12 or older. And so as you go down the list, it highlights that you've got any pain reliever, then you've got hydrocodone, oxycodone, codeine, and you've got the numbers and percentages of people funneling down based on the specific type of opioid that's being used. So what I'd like to do now is invite Dr. Mental to join us, and I'm best, but she's bestest. So welcome, Linda.
All right, thanks, David. So those are sobering statistics that you just heard, and if you don't remember all the specifics of them, just remember it's a massive problem. But we're both therapists, and one of the things that we always like to know as therapists is how did we get here? Why are we in such a crisis at this point? So I'm going to do a little bit of history with you so you can get some idea of how we came to this point, because it's important for prevention to understand the factors that were present when this crisis developed. So currently, the CDC, the Centers for Disease Control and Prevention, issued guidelines for prescribing opioids for chronic pain. Now, I'm going to focus more of this on pain because, as David said, a lot of the opioid use then becomes a problem when we're dealing with pain. This was part of an effort to push doctors to prescribe pain medications responsibly. So the recent guidelines, all the doctors are going and they're taking CMEs and they're looking at how to prescribe appropriately based on the crisis. Last year, in another attempt to slow the prescriptive drug epidemic, the U.S. Food and Drug Administration announced that immediate release opioid painkillers, such as the one David's been talking about, oxycodone and fentanyl, have to carry a black box warning about the risk of abuse, the addiction possibilities, overdose, and death. And then President Trump recently declared the opioid crisis a national emergency. So the question is, again, how do we get to this point? Well, historians say that it wasn't until after the American Civil War that the use and the misuse of opioids became widely spread in the United States. Some of the first addicts were morphine-dependent soldiers and veterans of war who suffered from physical and psychological effects. You might have read this in history. It was called soldier's disease. But let's fast forward to the mid and late 1970s when Percocet and Vicodin came on the market. The seed for the crisis began when the World Health Organization identified, and I quote, "inadequate treatment for pain, a serious public health concern," end of quote. And they encourage physicians to prescribe more opioids, especially for cancer patients. Then in January of 1980, the New England Journal of Medicine pushed back on the popular thought that using opioids to treat chronic pain was a little bit risky. They printed an 11-line article by Jane Porter and Dr. Herschel Jick in which they mentioned their analysis of almost 12,000 patients who were treated with narcotics. They wrote, and again I quote, "The development of an addiction is rare in medical patients with no history of addiction." Now, doctors had been taught that prescribing these opioids was a problem, and so they were taught to avoid using them. However, a retrospective study published in 1986 by Portnoy and Foley noted a very low risk of iatrogenic addiction in 38 patients whose non-malignant chronic pain was managed with opioids. This small study was cited frequently through the late 1980s and 1990s in support of aggressive opioid pain management, despite significant limitations to that study. It was a small study, it had a small sample size, and I don't think the authors really intended it probably to be used that way. So overall, what was happening then in our country was that patients with terminal diseases and illnesses were now being treated more with prescription opioids. And doctors and researchers were interested in opioids for treating chronic pain because we were having difficulty understanding how to treat it. Now, according to a 2003 report by Congress by the U.S. General Accounting Office, in 1995, the American Pain Society introduced the pain as the fifth vital sign. This was a campaign that they had promoting increased assessment and treatment of pain. Now, this wasn't a bad thing. This meant that in addition to the protocol of checking body temperature, pulse rate, respiratory rate, blood pressure, doctors began asking their patients to rate their pain on a scale of 1 to 10. And if you've gone to a physician recently, which I did today, I was asked to rate my pain on a scale from 1 to 10. So soon it became that painkillers were not being just used to treat cancer patients, but now we were looking at treatment for rheumatoid arthritis, chronic back problems, osteoarthritis. And when pain began to be described as the fifth vital sign, prescriptions to treat it soared. So, however, it's difficult not to recognize the role of pharmaceutical companies and what they did in terms of the crisis. So, according to Richard Gunderman of the University of Indiana, companies like Purdue Pharma aggressively marketed OxyContin, knowing that it could be easily abused, and prescriptions again soared. In 1998, Purdue Pharma created a video promotion called I Got My Life Back. It followed 6 people who suffered from chronic pain and were treated with OxyContin. The company distributed 15,000 copies of the video to be used in the physician waiting rooms. You know those videos that loop over and over in your physician's waiting room? That's where they put this. And so this is what they said. This is what a doctor says on that video series, and I'm going to quote this about opioids. They don't wear out, they go on working, they do not have serious medical side effects. These drugs are our best strong pain medications and should be used much more for patients in pain. A year after the video came out, the overall number of opioid painkillers prescriptions just jumped by about 11 million. 7 years later, the company and 3 of its executives were charged with misbranding its drugs and downplaying the possibility of addiction. However, kind of the damage was done, and physicians began writing increased prescriptions for pain conditions, and they believed that patients in true pain would not get addicted. Pharmaceutical companies reassured the medical community that patients would not become addicted to prescription opioid pain relievers, and healthcare providers began to prescribe them at a much greater rate. Even the Joint Commission, and that's the accrediting body for hospitals, printed a book in 2000 for purchase by doctors as a part of their continuing education seminars. The book cited studies that claimed, quote, "There is no evidence that addiction is a significant issue when persons are given opioids for pain control." It also called doctors' concerns about addiction side effects, and again I quote, "inaccurate and exaggerated." The book was sponsored by Purdue Pharma. The widely held belief that short-term use of opioids had a low risk of addiction was an important contributor to the inappropriate prescribing patterns for opioids. And that in part led to this current opioid addiction epidemic. And in fact, in 2001, medical centers and their doctors were required to examine their patients' pain levels, and the Joint Commission would give hospitals requirements for improvements if they failed to meet the standard. By the mid-2000s, when opioid medications like OxyContin were being regularly prescribed, it became very clear that many chronic pain patients were on a spiral into addiction. And then, as David was talking about, many of these prescription opioid users switched to the use of illicit drugs, such as heroin, as he mentioned. The reasons, again, that transition from prescription opioids to heroin, of course, the reasons vary for a lot of people, but as he mentioned, they were easier, they were more available, there was a lower cost, and they have greater euphoria attached to them. So what is more concerning today is the illegal market and the move towards these synthetic opioids that David was talking about, like fentanyl, making everything about this epidemic just so much harder to deal with. The dogs can't sniff it. You can send it through the mail, which is very scary. Fentanyl is much stronger than heroin, about 50 times stronger. 2 milligrams can kill you. It also costs less, since it doesn't take as much of a dose as heroin or other drugs for the user to actually get high. So finally, let me say that people use drugs for a lot of reasons. They use them to feel good, they use them to get high, they use them to fit in, to feel relaxed, to increase energy, maybe to feel powerful, to numb, to escape internal pain, and to increase self-confidence. Others use because they're curious, to deal, maybe they just want to see what they're about, and they start off as a recreational user, or they use them to deal with emotional distress like a divorce. But many use opioid medications to deal with pain, both acute pain and chronic pain, and to decrease that physical pain. However, the fun really ends because the initial sense of control leads to a lack of control in the long run. Problems develop, negative consequences occur, Denial sets in, abuse becomes compulsive, as David will talk about. It is more and more difficult to get high because of tolerance, and then you need more. Drug use may begin voluntarily for some people, but it ends up not being something that they choose, but something that will affect their survival. In the end, opioids are not effective for chronic pain and can lead to addiction. David?
Okay, want to talk briefly about just the process of addiction generally, some aspects to that, and then start zooming in on unique aspects to addiction to the opioid medications. A couple of things to keep in mind. Remember the stages of change, the trans-theoretical model: pre-contemplation, contemplation, preparation, action, maintenance, and the stage of change model actually has termination, and then of course relapse and recycling can be part of that. DiClemente had a brilliant moment of insight at some point, and in his 2003 book really laid out the case for the stages of change are not just about changing out of addiction. Remember, people don't start off addicted. So the stages of change actually can apply to going into addiction as well. So just keep that in mind as we go along. Second thing to keep in mind is just the basics of learning, classical conditioning. Remember the Pavlov's dog, ring the bell, meat, powder, salivate. Those repeated pairings, all of a sudden you ring the bell and you get the response of salivation. Typically dogs don't respond to bells ringing like that. Okay, classical conditioning happens as someone uses. Certainly operant conditioning comes into play. Remember, you've got positive reinforcement, reinforcement being anything that increases the likelihood of repeating a behavior. Positive reinforcement is about the experience of pleasurable, rewarding kinds of situations like euphoria, extreme relaxation, those kinds of things. Negative reinforcement is not penalty or punishment. Negative reinforcement is the engaging in a behavior. You are reinforced for doing that behavior when you relieve noxious situations, painful circumstances. So think in terms of pain relief, anxiety reduction, things like that. So part of what happens is there's some evidence accumulating that folks who move on and become addicted experience both classical conditioning and operant conditioning more intensely, so that the highs are higher and the lows are lower, but the individual person experiencing isn't aware that their situation may be a little more extreme than is typical. And of course, excuse me, of course, as use goes on, the euphoria passes, then you start getting other kinds of effects going on, oftentimes withdrawal symptoms, and the using of a drug to relieve withdrawal symptoms, that would be another example of that negative reinforcement. So you can get positive and negative reinforcement acting synergistically to move someone down through the process of addiction. A basic 4-stage model of the process of addiction. I've been familiar with this one for like 30-some years. Recently went back into the literature to see if there's been any kind of significant changes in these stage models of addiction, and basically these stages still pretty well hold up. You'll find 3-stage models, 6-stage models, things like that. But this is a fairly common one. So think of use, and then think of the stage experimentation, where curiosity is typically the motivating factor. 1 or 2 times you experiment, and at that point it's not an experiment anymore. How many times does it take to learn, right? The next stage, if someone continues to use, typically in a process of addiction, you'll have a social phase. Again, still using, genuine social use. It's non-patterned, special occasions, there aren't any consequences, significant ones anyway, that regularly show up. By definition, other people are around. The use is just part of the occasion. It's not the reason for the season, it's just simply part of it. So that if the substance is there or not there, it really doesn't matter. It's about the social event, it just happens to be there. All right, as someone continues to use and use progresses, there's a critical change, there's a critical change point that occurs in this process. And for me, identifying that early on is pretty important. And so it tends to crowd a lot of people who think their use may be social when it might be something different or becoming something different. And the first cutoff for me, the first mark of that transition is when reasons start becoming attached to the use. So this isn't diagnostic, this is just conceptual. So if someone's, a couple of nights a week I might have a couple of drinks to help me relax after work. They've just attached a reason to their use that's different than social use. So it can even be something early on like that represents a pretty important shift. As use continues, also think in terms of when consequences begin to occur. So when reasons and consequences become attached to the use, that's when it becomes something different. As you progress on, that can float into this category called misuse, where you're now using the substance for things other than social events, and in the situation with opioids, other than as prescribed. And so you have to be careful and aware of those transitions. When you attach that next phase, as you move into that, when reasons and consequences become attached to it, you move into the medicinal phase of use. And again, if consequences start showing up and the use continues to escalate, and now use is about relieving consequences, it tends to be more isolated use, even though someone may still use in social settings. There may start to be individual private use. It's not about the celebration or the event, it becomes about the using experience itself. So just increasingly, there is a constriction of lifestyle and focus that starts happening around the use of the substance. Again, as use progresses, you can get into abuse, and then you can get into dependence. All right, now dependence, think tolerance and withdrawal. I do make a distinction between someone can be physically dependent and not addicted. They really are two different things conceptually. So we have to keep those kinds of things separate. An example, my 93-year-old mother who just passed away a few months back, just had horrible back situation, compression fractures in her back and things like that. She was 90-some years old. She really couldn't move. She couldn't do exercise. If you stretched her out, you risked cracking her back. It was that bad osteoporotic. I mean, it was just crumbling. So there wasn't much that she could do. So she was on heavy doses of some of these pain medications, but she never craved, she never doctor shopped, she never took more than was prescribed. When she was in a home in the last few years of her life, she didn't, try to get other people's medications. In other words, craving and loss of control that characterize addiction were not present for her. Now, if she had reduced or stopped her use, would she have gone through withdrawal? Absolutely. She sure would. Did she have tolerance built up? She sure did. Okay, but in my mind, she didn't cross over into that craving loss of control that is characteristic of addiction. That actually reflects the changes that they made in the DSM-5 and their conceptualization of the use disorders. So we just have to keep that in mind. All right, so as addiction occurs, and we look specifically at opioid use disorders and addiction to the opioids, I wanted to think through, all right, what are some of the unique aspects about the process of addiction to the opioids? So some of the things that I came up with, curiosity is not the motivation for those with pain. So the experimentation phase might be there for some, but typically it's going to be there for some who are already using other substances perhaps in illicit ways. In other words, somebody's first drug experience typically is not going to be with an opioid. So even if curiosity is the motive, curiosity about opioids is the motive, it may be with someone who is already using other substances or misusing them, perhaps even addicted to them. Another thought I had is most people who have opioid use disorder began with non-medical use of prescribed medications, most often someone else's. So a big part of this problem that Linda will speak to is because of the way we've been managing pain, there is just such widespread availability and there's just such an oversupply out there that people can get their hands on relatively easily. That is a large part of what's fueling this. So appropriate pain management is one of the keys to helping with this, both on the supply side and on the demand side. And so it's important that we consider other ways that pain can be managed effectively. Another thought I had was that the social use may just completely get bypassed. I'm not sure that, like with alcohol at a New Year's party where there might be a toast, or a wedding reception where there might be a couple of glasses of champagne, toasting the couple or whatever, I'm not sure there's that much of an equivalent with opioids. So it's almost like the experimentation phase and the social phase of this typical process of addiction just get bypassed. We keep in mind again that distinction of dependence, tolerance, and withdrawal, but for most not addiction. However, there are such large numbers that we just have massive numbers of people now becoming addicted because of the explosion in prescribing rates and those types of things. Another thought I had too was that people understand that if they're taking somebody else's prescription, it's not for them. And so just think of as someone becomes addicted and lifestyle continues to constrict, guilt and shame probably are more prominent in these, even if someone's in denial of those and not quite recognizing those. I believe there's also, it was hard to find any data on this specifically, but I believe there's probably higher rates of moderate and severe rather than mild compared to other substances. All right. Okay, so once addicted, there is a cycle of addiction that involves binge and intoxication, which I think relates to loss of control. There is a stage in that cycle of addiction. Once addicted, you've got a cycle, binge and intoxication, withdrawal and negative affect, and then a third stage is preoccupation and anticipation, or a craving aspect. Okay, once addicted, those things are cycling. And of course, the brain is involved in that. So when we look at the neurobiology of addiction, with the opioids and other substances as well, we have to consider the ventral tegmental area, which is widely known to be involved in the experience of reward and pleasure. That area is rich in dopaminergic cells, so dopamine is a primary neurotransmitter involved in reward salience and motivation. So you get psychological and emotional components, but you also get behavioral activation kinds of components as well. Pleasure and euphoria, ventral tegmental area is principally responsible for that. And then there are projections to limbic and cortical areas, emotional processing and experiencing areas, and also cortical, higher thinking kinds of areas. And so the limbic system and the ventral tegmental area and these cortical areas, those areas are also close to those responsible for learning and memory and other things like that. So there's this like concentrated process in the brain that once addicted, it all becomes about the addiction. It just becomes an all-encompassing thing from a brain perspective. There's also a structure in the brain called the nucleus accumbens, which is principally involved with pleasure, reinforcement, and reinforcement learning, which again is the behavioral component. So it's not just psychological, physiological, and emotional. It's also behavioral, and the behavior starts being driven through these brain processes as well. Prolonged exposure can actually change the set points in some of these brain systems so that the body habituates and there's neuroadaptation to the presence of the drug and the experience of the drug, and those factors come into play. And so the body basically develops new set points. And then if you don't meet those, you experience distress, discomfort. It's almost like your brain becomes more irritated. And of course, the solution is you've either got to withdraw and detox and all of that, or more of the drug. When you start experiencing these negative consequences, another system that we have to take into account is the hypothalamic pituitary adrenal axis, the HPA axis. And that involves the stress response pathway. So what happens is you take beginning, you get the euphoria, you get the relief, you get the positive reinforcement. As addiction develops, you then start using to relieve consequences. The negative reinforcement kicks in. You've got the neurobiological aspects of that occurring, so that withdrawal becomes a noxious situation for the body. It activates the HPA axis, the release of cortisol, one of the primary stress hormones, and then you kick into the body's stress response. And once again, what's the way to relieve that? And once addicted, of course, the way you relieve that is to ingest more of the substance. So the opioids really can, it's almost like they grease the brakes on this addictive process, both psychologically but also neurobiologically. It can happen very, very quickly, especially to folks that are predisposed toward that through family history. I think we also have to take a look at trauma histories. In other words, anyone who is experiencing chronic physical and or emotional pain, the opioids will probably rush them through this process quicker than usual. Linda?
So I think one of the messages there was that the neurobiology of the brain is really important to understand, because we have these sort of myths that we believe that, you know, the person isn't exercising enough willpower, maybe the person isn't, is weak somehow. But what happens, what David was just explaining, was the neurobiology of the brain. When it kicks in, it really rewires the brain. And then I liked the analogy about the greasing of the brakes, because it's like the prefrontal cortex is no longer in control. And there's even this part of the brain called the locus coeruleus that's screaming 911, and it's telling everybody that there's an alarm, and it's craving, and it wants that. And the prefrontal cortex sort of loses control. And then all that memory that David was talking about that is laid down in the amygdala and in the hippocampus, all of that is so important in terms of understanding that your brain is being hardwired then to actually respond to this craving and want these drugs. And at a point, people move from this impulsive use of drugs to compulsive use of drugs. And I think that is really important for us to understand when we're trying to get somebody off of these drugs. Okay, so I'm going to take just a few moments. I don't know that I have a lot on this, but I want to talk a little bit about the proper role of medication. So do we just throw opioids out and say these are terrible, we're not going to use them? Well, I think we need to be careful with the use of them, even when we're talking about acute pain. So there is a place for opioids with acute pain. For chronic pain, this is not the treatment. And we're finding out more and more that it's not effective to use opioids for chronic pain unless you're dealing with something like palliative care, terminal illnesses. But we're talking about just in general, for people that may have some backaches, some pains, they should not be on these medications for a long time, because they're not going to be effective. And all that's going to happen is that they're going to be addicted. Now, just tell you a little story. My daughter had her tonsils out and her adenoids out a while back when she was a teenager, and the surgeon who did the tonsillectomy sent us home with a prescription for some really hard core opioids, and I was kind of taken aback by that. And he goes, "Now you fill this," and the doctor was very well-meaning, but he said, "Now you fill this so she's ready," and I didn't fill it. I thought, she's a teenager. If she's in pain, I'll give her some Tylenol, maybe put something cold on her throat, and she can live through it. And so I was a little bit taken aback that without any kind of indication of what her pain levels would be, the expectation was that I get those pills. And then think about it. So if I'd filled the prescription, she didn't use it, then we have a bottle of OxyContin or Percocet or something sitting around. And this is where what David was talking about, where people share medications, or they sell them, or they give them to people, or teenagers find them in a cabinet, a medicine cabinet, and take them. So I think what I want to make really important here is you need to understand that for acute pain there is a place, and for chronic pain we're really not recommending opioids. Now, we need to understand that there's several kinds of pain that people deal with. So I wanted to make sure that we understood there's something called nociceptive pain related to tissue damage. There's something called visceral pain related to internal organs of the body's main cavities. Something called somatic pain that's caused by stimulation of pain receptors on either the surface of the body or the muscular skeletal tissues. There's something called neuropathic pain, which is nerve injury pain. And there's peripheral neuropathy, neuropathic pain as well, due to the damage of the peripheral nerve, and central pain, which arises from abnormal central nervous system activity. So I've just given you a whole bunch of kinds of pains, and physicians will manage this kind of pain, acute pain, sometimes with opioid, a very short course. Sometimes they'll use other things like nerve blocks or injections or other types of non-opioid medications to manage that pain. So people with acute pain are often candidates for a short run of opioid medications. And certainly, again, I'm just reminding you that people with cancer and terminal illness often need these opioids, like David was talking about with his mother, to function. But using opioids for chronic pain, and this is my message, is where we see problems and where we see addiction. They're just not effective to treat chronic pain. Why is that? Well, chronic pain is an abnormal functioning of the pain process. So when the brain has memory of chronic pain, which David talked about, the brain lays down memory of those pain pathways. When you have memory in your brain, so pain is in the brain, then that pain can persist. And the perception of pain, which is really important, because when we go to talk about how do we treat this, part of what we're treating is changing the perception of pain. And that's a cognitive behavioral way that we do that. But the perception of pain is also in your brain. So if you think about it, I have my medical students do this. I have them close their eyes and I say, okay, try in some way to feel the pain that you felt in one of the worst things that you ever remember. So for some people, it's childbirth. That would be a good one for me. Or some other kind of pain. Now recreate the pain. They can't recreate it because pain is in the brain. It's not here where you might have injured yourself. It's actually happening here in the brain. So that becomes important to remember when we're dealing with treatment, because the perception of pain is influenced by your biology, which we've been talking about, but also your thoughts, psychology, also emotions, and the emotional memories that you have with that, and even the culture, your cultural context for pain. And this is why chronic pain responds well to mind and cognitive treatments, as we'll discuss in a little bit. So the problem is that so many people are using these opioids to treat chronic pain, and we should not be taking those, and we need other approaches to pain. So we have to reverse this and try to think about with chronic pain, we have to do something different. Now, in the last few minutes, I want to just say something about, you've probably heard of naloxone or the brand name Narcan that's used by first responders. You'll see lots of stories about this in the news these days. Naloxone is used for patients with a high risk for opioid overdose, like someone with a history of substance abuse, including alcohol abuse. Naloxone is also used to treat a narcotic overdose in emergency situations. So it attaches to the same parts of the brain that receives heroin and other opioids, and it blocks the opioids for 30 to 90 minutes to reverse the respiratory depression that would otherwise lead to death from overdose. So it's the respiration that people usually die from in that. So it quickly restores normal breathing, and it can save the life of someone who is overdosing on opioids. Naloxone distribution programs give naloxone kits to opioid users, their friends, their families, and others who may find themselves in a position to actually go out and save the life of someone at risk for an opioid addiction. Naloxone only works if the person has opioids in their system. The medication has no effect if opioids are absent, and I think that's important to remember. So you'll see first responders, police officers, and you'll hear about the controversy of this all over the country. Should police departments be armed with Narcan every time they go out and they respond? And they go to a response, they see somebody who's looking blue, looks out of it, completely ready to overdose and die, and they shoot him up with one of these naloxone injections, and the person comes back with their respiration and they don't overdose. So naloxone can be given in a nasal spray, which is less used than the auto-injectors. So you can even put those through somebody's pant leg with something, like a clothing article on. You can stick it right through there and get it into either the thigh or the arm of a person, which are the two typical places they're injected. It can also be purchased in pharmacies without a prescription. And law enforcement, like I mentioned, emergency medical services, and community-based naloxone distribution programs all use this when someone is overdosing for opioids. So the message, the takeaway, this part, is that we're at this crisis. We are at a point where we understand why we got here with a lot of bad information, misinformation, maybe misinformation on purpose in some cases to make money. But doctors who were thinking that they were doing a good job by having pain as the fifth vital sign, bringing that in, and then beginning to use that as a way of assessing pain, but then being told that there really aren't any risks or addiction. We're finding out there are. The more we understand, as David talked about, the neurobiology of the brain, we can quickly see how someone can go from impulsive use to compulsive use to being addicted. And now we have all these people that are walking around our streets where we need to actually intervene at times with these Narcan injections to save people's life. It's a sad state of affairs, but hopefully there's hope, and we're going to talk about, as we get later into our program, some of the non-pharm ways that we can deal with the opioid crisis and opioid addiction. We need to have compassion on people who are in this place because it is so difficult to get off of these drugs, but it can be done. David?
We're going to take a 5-minute break, and we'll be back this next segment. After the break, we'll be talking about treatment for opioid use disorder, but also non-pharmacological treatment for pain. Welcome back from break. I want to talk now about various treatment options available for those who have become addicted to opioids and are somewhere on that opioid use disorder spectrum. Remember, more severe, the more severe the addiction, the more likely they're going to need restrictive alternatives to their treatment. So the more structure is involved. I was just mentioning to Linda during the break that I have become a reluctant, but now a believer, that medication-assisted treatment is really going to be a key component for those who are addicted to the opioid use disorders. There are 3 primary medications available to help folks who are motivated to do something about the opioid addiction. Methadone, of course, is a common drug that's been used for a long, long time. It itself is an opioid, but it blocks the euphoric effects, and it reduces the withdrawal symptoms. So it helps someone who is trying to come off of the opioid they're addicted to deal with their physical tolerance and those indications that have occurred. And so it blocks euphoric effects so you don't get the positive reinforcement, but it also helps reduce any kind of painful withdrawal symptoms. So that's one medication that can be helpful. Buprenorphine diminishes the effects of dependency. Doesn't act directly on any of the euphoric neurotransmitter sites, but it diminishes effects of dependency. Naltrexone blocks euphoric effects, it reduces cravings, and it binds and blocks versus activates opioid receptors. So you can start to see where there are medications available that can help someone as they're trying to get through and recover from opioid addiction. I think this is one area where our thinking is going to have to expand and change. I think the church is going to have to become much more fluent in things related to addiction and the brain and medications. And I think we just have to look at this problem for what it is and then look at the various options and solutions that we have available. Non-medication types of treatment available for opioid use disorder, very typical kinds of places in addiction recovery. Residential or inpatient treatments can be very, very helpful. You can get a lot of good work started in an inpatient facility where someone is just pulled back out of their world, and it gives them a chance to regroup, get used to the idea of recovery, get skills that might be needed to help them recover effectively, those kinds of things. So residential treatments are available. Group therapy has also been shown to be effective, and I think as we continue to look at this across American culture, again, the use of groups to bring like-minded people together who are about accomplishing a common goal. This may be another area where the church has a role to play. We'll talk more about that in our last segment. Individual psychotherapy is very important. Helping people process their individual journeys into and out of addiction, unique struggles. Individual psychotherapy, there's a lot of evidence that it can be helpful in non-medication pain management. A few years back, I was researching this area, and unfortunately, some of the information in the management of chronic pain, psychotherapy and counseling was maybe mentioned, and when it was mentioned, it wasn't described in detail. Now, that's not the only case, but I think that points to the need for counselors to educate themselves about appropriate pain management, become skillful at that, and then perhaps link that to other resources in the community. There's also the need to treat co-occurring disorders that go along with opioid use disorder, depression, anxiety disorders, those kinds of things, and then addressing other drug use disorders that may be present. So those are some of the types of treatment that are available for opioid use disorder. Some of the modalities that are showing a good bit of promise in working with those who are struggling with addiction to opioids. Cognitive behavioral therapy just rises up as one of the important modalities, and for me it just boils down to we're most of us as counselors are always going to be dealing with thoughts, behaviors, environments, emotions, and the way that life interacts with all of those. But specific cognitive behavioral techniques can be very helpful there. Motivational interviewing on the front end of things to help resolve ambivalence, to help deal with client resistance to treatment, to help engage. Again, think of motivational interviewing as a style, a way of approaching clients that reduces their resistance. I remember in the first edition of Motivational Interviewing book, William Miller and Stephen Rolnick put this quote in their book, and that was, and remember this was to addictive, the addiction treatment professionals back in the 1991, and they made this statement: client resistance is a counselor problem. And boy, that set the world on fire right there. And so just think of the journey of motivational interviewing through addiction treatment generally. And then think of these aspects that are unique to the opioid addiction, particularly with people who haven't struggled with other substances but now find themselves addicted to opioids and prescribed medications that they've been misusing, and they've not been addicted to things before. I did spoke at a men's conference probably about a year ago now, maybe not even quite that long. And I had men coming up after the session talking about their grandmothers that had become addicted to opioids, and they were moving towards seeking out sources of heroin. And we're talking in rural, conservative communities and things like that. So imagine the shame that these folks are carrying around with them. And so motivational interviewing as a technique, but also as a style, a way of engaging people who are struggling to help reduce their defensiveness, but more importantly, to help them buy into the idea of recovery and treatment. And then along with that, motivational enhancement therapy, where it's motivational interviewing plus, where you do good assessment and you provide good structured feedback with motivational interviewing folded into that. And so you help the client take that information, work it around, come to some determination of what they want to do with that information, and just help them walk through that. Motivational enhancement therapy can be used as standalone, but it can also plug into other modalities and types of treatment. So it's very amenable, very flexible, and it'll be a nice way to engage folks who are struggling with this as we move forward and try to do something about these vast numbers of people that now find themselves addicted to the opioids. Another modality are mindfulness-based stress reduction. Imagine non-medical interventions for reducing life stress so that HPA axis doesn't get activated, and if it does, there are non-medical ways to reduce that down, to bring comfort and reduce painful statuses and situations within the body and the mind, and certainly Christianly, and the spirit. Think body, soul, and spirit, right? Mindfulness-based stress reduction can be very helpful as someone is walking through this. Then if recovery starts to become stable, these moments of craving that can occur, having ways and strategies for navigating through that can be very helpful to folks as well. So the idea really behind this is there are just a myriad of options out there. And again, pretty consistent with motivational interviewing. I believe we need to first understand that we have a menu of options that we can pick and choose from. So it's going to require us to focus on the individual who's in front of us, understand basic guidelines and principles of treatment, but have the individual in front of us and then find these evidence-based practices, and as more information develops, that will become even clearer to us. But we need to plug these things in and come up with combinations of these for each individual according to what they need living in their world. And so this is a public health epidemic. We need to respond to it that way. And that means that everybody's going to have a role to play in this. So I just want to, consistent with what Linda has mentioned several times, we have a lot of hope for resolving this crisis. There are things that can be done to do this. We are now in the position of determining, okay, are we going to do something about this or not?
So let me just say one more thing about motivational interviewing, because I love that David brought that up, and it's one of the things I teach students. It's one of the things I use personally with any kind of addiction, because if you remembered at the beginning, David talked about the stages of change. He talked about moving people from pre-contemplation to contemplation to preparation to action and then to maintenance. And this is important because with drug use, as a lot of you know, in addiction, people are a lot of times in the pre-contemplation stage where they're saying, I don't have a problem, I don't understand. And it isn't really to your benefit to try to convince people that they have a problem, because we know with addiction, there is a lot of denial about that problem. So what I love about using the motivational interviewing is the quote that he gave you is that what you end up doing is you roll with the resistance. So you go with the resistance of the client. You let them continue to have that, and you try to get them to elicit reasons for change. Not you giving them reasons, not you trying to convince them, which usually doesn't do well at all in addiction work, but getting them to say, you know, on a scale from 1 to 10, how important would it be for you to change? Or what is your confidence level that you can change? You have a 4, why not a 1? And then get the person to start talking about this and start moving them into contemplation where they're deciding the pros and cons, and then hopefully into eventually that action stage. So I would put a real plug in. Glad you talked about it, David. I didn't use it because I knew you were gonna talk about that. Well, in the short time that I've got left, I'm going to briefly touch on 11 non-pharm interventions that fall into 2 broad categories. We're going to talk about self-regulation strategies and interventions, and then behavioral approaches. And we're going to talk about this in relation to chronic pain so that we're not using opioids for that treatment. And so one of the things that we know in terms of using these types of non-pharm interventions, the patient's defensiveness in terms of their willingness to get off the opioids, you have to assess that and make sure that they're willing to do this. Their level of knowledge in terms of understanding how pain works. Once you begin to talk to people about pain is in the brain, pain pathways have been laid down. It's like carving neural pathways in the snow when you ski, that they're there and you go fast. And helping patients understand more about how pain works, and then assessing their attitude towards mind-body relationships and treatments. Once you can kind of get through those issues and get people on board with you, there's a lot more that we can do. So how many of you remember the story of Louis Samperini in the movie Unbroken? That's a really great movie to illustrate one of the ways that you can deal with intense pain. So one of the things that he did was he used what we call cognitive regulation or cognitive self-regulation strategies, such as imagery and distraction, in order to alter his perceptions of pain. So remember, perception of pain is in the brain, and that's changeable based on changing your perceptions. The more attention that you give to chronic pain, the more it worsens the pain. So people who are walking around going, oh, my shoulder hurts, my shoulder hurts, my shoulder, oh. The more you do that, the more attention you give to it, the more your pain is going to increase. So many of the interventions that we have to deal and to treat with chronic pain involve shifting that attention and using sort of like a grand scheme of distraction in terms of getting people to take their attention away from the pain. Because again, we know attention to pain increases pain. So the most common approaches are the cognitive behavioral ones that David mentioned with addictions as well. The goal here is to get the pain under the person's control. And this is again because thoughts, emotions, behaviors, perception, all of that influences the pain experience. So the goal here is to help people with pain coping and adjusting their expectations and adjusting their thoughts and adjusting their emotions, because those things will turn down the volume of pain or they can turn up the volume of pain. So for instance, if you are someone who's very fearful about your pain, oh, I can't do that because something might happen, it might worsen, you're going to turn up the volume on pain. So fear, worry, anger turns up the volume on pain. Depression turns up the volume on pain. We don't always think about depression with pain, but that is one of the key emotions that can turn up the volume. In terms of our thoughts, one of the things that we can do to turn up the volume on pain is to have catastrophizing thoughts. So, the idea that, something's wrong, my shoulder hurts, I'm getting worse, I'm going to have some pills, I'm going to have something to do to get rid of this. That sort of catastrophic thinking process that people go through can turn up the volume. Well, let me move on to something related to cognitive behavioral therapy, which is also cognitive restructuring, which is that sort of reframing that you're going to do with the beliefs and the attitudes and the expectations related to chronic pain. So interventions that deal with those negative cognitions that we've been talking about, and also your beliefs and assumptions about pain and chronic pain. So again, that catastrophizing, expectations that you have that it's going to get worse, it's never going to get better, I'm not going to be able to live like this, I'm not going to be able to work, I'm not going to be able to function. If you believe those things, you're going to ramp up the volume on pain. If you believe, on the other hand, and you have the confidence that you can deal with this pain and you can get it under your control, then you will manage pain, and that will be better for you. So working on that reframing is very important, and helping people learning to identify the and challenge, really, their ideas about their self-defeating thoughts, their maladaptive negative thoughts, such as pain means, I'm going to need more surgery or more pills, and then replacing those negative thoughts with constructive and adaptive thoughts when confronted with pain. And certainly, with our knowledge of the Bible, we can put things in there like, I can do all things through Christ who strengthens me, my Lord is a present help in times of trouble. Scriptures like that, where we can put those thoughts in our mind that God will get us through this to the other side. Another group of non-pharm treatments are relaxation techniques. And there is strong evidence from the National Institutes of Health for the mind-body treatments for chronic pain. Specifically, relaxation techniques like guided imagery, progressive muscle relaxation, meditation, so meditating on scripture, maybe what we would call in the Christian world contemplative prayer, and music therapy, some forms of hypnosis, which could be just relaxation techniques, and then biofeedback. So let me talk about a few of those as we go, because relaxation is really a good thing to use for chronic pain. Now, think about it. You have to practice relaxation. You have to do the strategies, and it's a whole lot more time-consuming than popping a pill. So one of the things I run into is people don't want to practice these. They don't want to learn these. They just want to take a pill and feel better. But you've got to get around that, because relaxation training lowers anxiety, it alters the sympathetic activity that David was talking about, and it reduces generalized arousal and muscle tension. And when you get tense, you get more pain. And so it provides, in a lot of ways, a way to distract the brain. So think about it. If you have to have a dental procedure, and you are like in the chair like this, which is what I used to be like all the time, and you're like, and you're tensing up, you're going to have more pain if he gives you a shot or does something to you than if you can relax that. So the relaxation techniques are helping the body get to that state of relaxation. Guided imagery is a type of relaxation in which you create basically a guided tour through the use of imagery. So some people like to imagine themselves on a beach. This is my favorite one. On a beach with the warm breeze blowing, and you have to do this very sensory when you do guided imagery. There are actually tapes that you can listen to free on the internet. But it's people taking you through this. You're now walking on the beach. You feel the moist sand between your toes. You hear, the seagulls in the background. And I'm getting relaxed already just talking about this. But these are great. Some people like mountain scenes. I'm in a cabin with the snow falling softly and a fireplace crackling, and I can smell the wood burning, and it brings them into a place of relaxation. Some people like tapes on the woods where they're out into nature. Those kind of creep me out because I'm always thinking about the bugs and all the other things that could happen. But whatever that is, a guided imagery tour can be a way of distracting you away from the pain, and it it is a good alternative that gets you from focusing on that pain at the moment, and this way you modulate the pain. Progressive muscle relaxation is another one, and I really like this because of the difference between tension in the body and relaxation in the body. And so all the patient is taught is how to tense up different muscle groups. So you start with every muscle group. So you might start with your hand, clench your fist, hold it for 5 seconds, and then relax your fist. And you go through all the muscles in the body until your whole body is in a state of relaxation. And you help people differentiate between the feeling of tension and the feeling of relaxation so that they can cue themselves then when they're starting to tense up with pain. You can cue yourself after you practice this over and over. And I've used this for my OBGYN appointments. I've used this at the dentist. You can use this with any kind of chronic pain where you just cue yourself and go, relax. There's also something called mindful meditation. And this is where you have sort of a detached view of the pain sensations, resulting in lower levels of reactivity to pain. So a detached view can lead to an uncoupling of the affective and the sensory interpretation of pain, so you're interrupting those pathways. I like to use scripture as a source of meditation. I think scripture really helps me keep my mind stayed on God, which he promises then to keep me in peace. Another one is music therapy. Now, music therapy can impact pain when you're given a choice of the music. So the music should be tailored to you and what makes you relaxed and what you like. So I wouldn't suggest listening to like maybe heavy metal, or wouldn't suggest that anyway, but or hip hop or something that's going to be like real crazy. You want a choice of music that is relaxing to you. And we know that classical music does that for a lot of people. Some soothing, maybe Gregorian kind of chant-like music is a good a way to start that relaxation. It's diversional, and it has associative qualities that distract you again from the pain and from the adverse nature of a stimulus that might prompt the pain. Music may also have a powerful impact on reducing the emotional components of pain, such as fear and anxiety, thus mediating the very perception that you would have of pain. Individual music preferences, like I said, are an important factor to consider. Music may also stimulate the release of endogenous opiates, right? The endogenous opiates that are in the central nervous system, which can modulate then the perception of the sensory and affective components of pain. It distracts from pain, it changes the emotional experience, basically. Music may also distract by inhibiting pain through this selective attention that is mediated by the thalamus, which is the kind of the air traffic controller of the brain, which alerts the prefrontal cortex, that thinking part of the brain, to the sound rather than to the painful stimulus. So music is a great way to distract and to meditate and to decrease pain sensations. Okay, another one is biofeedback, in which body sensors, a lot of you have seen this, are attached to a computer, and they enable the patient to achieve relaxation, which then can increase pain tolerance, decrease again that emotional distress, and even relax specific muscle spasms. So the physiological self-control that you're doing in biofeedback leads to a sense of control, better coping skills, and actually hopefulness. I've seen this used a lot with migraine patients, where they use biofeedback to mitigate the migraine, and they actually watch they can actually take their pain levels down by watching the monitor on the biofeedback machine. So it works really great. Facial pain syndromes, fibromyalgia. A lot of people have used this for that, and any kind of pain that's exacerbated by stress and anxiety. All right, a few more that I want to mention. Coping skills training. So the idea here is to stop the ineffective coping styles, such as the catastrophizing that we talked about, but more importantly, the avoidance that comes with pain. So a lot of times when people have pain, they just avoid doing things rather than pushing themselves to do something, and they're engaging in a lot of denial at that point. So another point with this in the terms of coping styles is with families, that if family members actually reinforce wellness. So instead of attending to every statement you make about, oh, I'm in so much pain, I just feel terrible today, and a family member goes, oh, I'm so sorry, what can I do? If a family member instead says, well, let's just reinforce wellness. So if somebody says, well, I'm better today, you're better today, that's great. What's better about you today? What feels like you can handle? Why do you feel like you can handle the pain a little bit better today? So again, attending to what we call enforcing well talk. And you'd be surprised because a lot of times people get a lot of secondary gain from the illness talk. And so you're shifting, again, the focus, and family members can participate in this one, which I really like. All right, what about physical activity? Maybe you're thinking, what? I'm in pain. Why do I want to do that? But really, physical activity in chronic pain patients has been linked to improved physical and psychosocial outcomes. And physical exercise has also been shown to have positive impacts on flexibility, on social functioning, and actually an overall quality of life. So the key is to get people over this sort of what we call self-regulatory fatigue and be willing to do those exercises. And one approach that helps with that is, so we're not going to say, okay, you're in pain now, go hike that mountain over there, and good luck with that. Instead, we're going to do something called activity pacing, which involves the scheduling of rest periods so that the patient doesn't overdo, and then an activity, then you do a little bit more. You don't want to do too much. You don't want to sabotage their practice or their progress, but it can be very beneficial for pain patients because you're getting them back up, you're getting them to move a little bit, and you're re-engaging. Now, we don't say, what was the saying so many years ago? No pain, no gain. We're not really going with that. So we're saying you do have pain, then kind of slow it down, pull back a little bit, but keep moving forward each time. The point of physical exercise is so you can stop the avoidance cycle. Because again, a lot of times when people are in pain, they just want to avoid instead of doing something. I know this is a little bit harder to get people to do. This is kind of like with depression, where you're trying to get people up, you're trying to get them motivated, and it's like a depressed person is doing the same thing. I want to stay in bed. I don't really want to get up. I don't really want to do this. But what do we do for people who are depressed? We get them up, we get them moving, we get those natural endorphins in the brain going, we get them feeling better. This is what we call behavioral activation. We act as if we can do it, and we start moving in that direction. And as we do that, and our body cooperates, we're breaking that cycle of avoidance. David talked a little bit about group therapy for addictive patients. I want to talk about supportive and group therapy for pain patients, because groups always help people, like he said, see that you're not alone in your suffering. And if you get a group of people together who maybe are struggling with fibromyalgia or some other pain syndrome, then they can become a support system to people, to each other. They can develop a little bit of community, and here's where you can really focus on those coping skills, so that you're saying to each other, maybe you're with each other, you're saying, wait, you're doing a whole bunch of that sick talk, let's do well talk. Wait, you stayed in bed, you didn't try what the physical therapist told you to do, maybe you need to get up and you need to do that, a little bit more of that. So in a group, you can actually promote the behavior change that you want to see. You can also educate people in the group about pain and about how chronic pain isn't going to get better with opioids. And I think that's so important. I know a few years ago, I don't remember, maybe it was just a year ago, there was a physician, and don't have that story in front of me, so I probably won't get the details right, but there was an internist, an internal medicine physician in South Bend, Indiana, who refused to give his chronic pain patient more opioids. And because, as we mentioned at the beginning of the program, that there are now these black bloc restrictions, there are now prescribing guidelines that physicians have to do, he just said, I'm not going to do it because now we know it doesn't help and this isn't going to help you. And I believe it was her husband who came back and shot him and killed him in the parking lot of his office. So when we talk about the craving and the dependence and the addiction that's involved in some of these wanting these drugs, we're talking about something pretty powerful that makes people do things that they wouldn't do if they weren't in an addictive state. And then finally, I want to talk about one last one, which is stress management. You have to reduce the perceived stress that people have in their life in order to help help pain. Because the more the stress goes up, the more the pain goes up with it. You can do this with humor. You can do this with typical stress management techniques. Sometimes pain diaries will help people to identify the stressful situations so they can look at the pattern and go, oh, whenever I did this, I was having more pain. So when I'm with my boss or when I'm dealing with my mother-in-law or whatever the stressful situation is, that's when my pain seems to go back up. So I hope you can see, that's 11 right there, and I could have kept going. There are a whole bunch more. But what the point of this is we want you to see that there are a number of non-pharm treatments for chronic pain, and they are more effective, in fact, than any of the opioids that we've been talking about, especially for chronic pain. So what is the reluctance? Well, these take time. They're often not reimbursed by insurance companies. You have to practice them. You have to retrain yourself over time. So consider that with, I could pop a pill and I'll feel better instantly. We live in an instant society where we want everything right now, and we don't like the idea of suffering at all. So we have to, again, change that paradigm, and I think the theology of the church in which we embrace suffering for a time is probably going to be helpful in getting people to change their way of looking at chronic pain. So hopefully those are a few suggestions. We're going to take a brief break for 5 minutes, and then we'll be back and we'll take your questions and we'll do some Q&A.
We meet our residents where they are, and what I mean by that is we take a gentle and loving approach to treatment. We really understand that recovery is a process, and it can start from anywhere, and we're willing to go as slowly as a woman needs to go or as quickly as a woman needs to go, depending on what she needs.
Oftentimes, there's really no commitment to change when they first enter treatment, and we're well aware of that. We have an entire multidisciplinary team to attend to all of the different issues, the features of the diseases that they're presenting with. And we set a pace that's comfortable and feels safe for each client and work with them.
I think the spirit of the staff at Timberline Knolls is a very empathic, warm, and loving spirit, so that each woman feels that they're met at their own level and are helped to go at their own pace in their recovery.
The staff is incredibly enthusiastic here about the work that we do, and it's contagious often, and it actually does make an impact on the residents who enter. If we walk in having faith in what we do, then it's a little easier for them to have faith in what they're capable of accomplishing while they're here.
The biggest way the staff at TK embody hope and healing for women seeking recovery is by living it themselves. One of the best things we can do for any of our residents is living happy, joyous, and free lives, and living by the principles that we're trying to impart to our residents to help them foster their healing.
It's such a joyous event when we are all able to experience a resident finally seeing the light in their recovery. These are just the most courageous women that you'd ever want to meet. I'm just very proud that I'm able to work with them here.
Hi, and welcome to the Q&A portion of today's webinar. I'm Dr. Eric Scalise, good friend and colleague with our presenters, Dr. Linda Mintle, Dr. David Jenkins. And first of all, thanks. That was really, really good, informative things that you shared. So I want to have some dialogue. We do have some questions that people sent in while you were presenting. And we'll just kind of have a conversation and invite you all. And if you still have questions and you want to send them in, that's fine as well. I want to talk a little bit on the faith piece as well, and we'll take some questions and the role of faith. But one of the things I want to say is when it comes to addiction, and we hear this in the faith community a lot, it's always disease or choice. And I realize with alcohol, which you have maybe the longest history of some research and some of the genetic research there, but how do you address that with people of faith when they're like, well, this is just choices people are making versus, no, some people may have some things going on with their bodies. Either, Linda? You study this and teach this, at med school. So
right. So it a lot of times begins with choice, right? Because an addiction isn't, and we're talking about drugs, it's not something you have to have. And in fact, the best prevention is always to never start, right? So that's the best thing.
Right.
So obviously there is a choice at the beginning to use, to try, to experiment, to whatever at the beginning. But I really have fallen into the category where I do see it as a disease because of the way we have dealt with understanding what happens now in the brain and how the prefrontal lobe gets hijacked and all these things begin to happen in the brain that do make it very difficult. I was just in a big opioids and addiction conference at the state level in Virginia with the Department of Health Professions, and every single person in there was saying this is a disease that we need to treat like diabetes, like cancer, like any other disease.
Yeah. Would you add anything to that?
Well,
David?
I'm reminded of the stages of change, right, into addiction. So there is this choice and motivation and all of that goes into getting there. I've said for a long time, I'm not anti-disease model. I'm anti-disease model only.
Yeah.
And this was actually just a very recent kind of thing for me. I've struggled with this concept and wrestled with it just like everybody else does. I am very comfortable with the idea of it as an acquired disease, much like heart disease. You've got predispositions to it, but choices and behavior and lifestyle, but once you got it, you got it. And you have to deal with it.
Right, so some of the research out, especially in alcohol use, and I know we're talking about opioids, but let me land there for a minute.
Right.
There is genetic predispositional markers, right?
Not
but
causality.
Right, but it does
right.
not necessarily, like you said, compel a person to start. But once certain people, maybe genetically, when a certain substance hits their system, they may wrestle a little bit more than the next person to say no, and it may kick into, like you said, a disease process.
There's also some really good research on what happens to the teen brain that's on addiction versus the adult brain.
Right.
And so I think that gives us a little bit more
Absolutely.
compelling evidence that if you can stop somebody from using until about after the age of 20, what it says, I know the brain doesn't fully develop till 25, but if you can get them to 20 without doing that, their chances of addiction from even experimentation is much lower. So there is something about the way the brain changes and rewires with addiction as the brain is developing in children and teens. So I think that's really important too.
And I suppose if choice was not part of the equation, no one would ever enter into recovery. Because you wouldn't be able to simply choose not to quote unquote have this disease. So
well, the first step is not I'm powerless over everything.
Right.
It's not I'm powerless. It's I'm powerless over opioids.
Right.
There's only one thing that the first step deals with being powerless over, and it's the substance of the behavior.
That's right.
Everything else you've got control. You have input in.
Yeah.
And I think if you listen to the stories of people who have had terrible addictions, the idea of choice, when they know they're losing everything. I mean,
Right.
they've lost their families, kids have been taken away, they've gone to prison, they've been found in an alley because they walked past, they were sober for 2 years, they walked past an alley where they used to use, the brain remembers that cue, triggers that craving, they're back on the street again. It doesn't feel like a lot of choice at that point.
I'm thinking too, in terms of type 1 and type 2 diabetes. And then with type 1 diabetes, think of the brittle diabetic who can do everything right, treatment-wise, lifestyle-wise, but just sometimes it just goes out of control. And I think an idea to consider is the possibility of type 1 and type 2 addiction. I believe there can be such brittle forms of addiction that a client was shopping in a grocery store, walked up the aisle, last thing she remembers, 4 days later wakes up after a binge. But she had been doing great in recovery, things were going well. And so I do believe that we have to have a good theology of the body,
Right.
that our bodies are fallen, our brains are not in their glorified state.
Right.
That when I die, my brain is going to rot like the rest of me, but it's also in view of God's redemption.
Right.
And one day it will be in its glorified state. I hope it's not in that already.
Yeah. And I suppose when you're talking
I've got
about
work to do.
opioids, they are rapidly addictive,
Right.
potentially
Right,
rapid.
right.
Right.
So if you have a brittle person, that could be. It's a different drug. But some years ago, and depending on your age, you might remember the story of Len Bias, who was selected #1, I think, out of the University of Maryland for the NBA to go to the Boston Celtics. And the night after the selection, he partied and OD'd on some cocaine, had a massive heart attack, and died. And here's somebody who was in the height of what you might think physical well-being, and yet there was parts of his body that were brittle, to use your words. David, let me throw out a question that came from Jim in Florida, and Linda, feel free to also add your thoughts. Jim asked, can you give examples of some of the consequences that users could experience when abusing opioids? So that's a pretty broad question. There could be both physiological and relational, but how would you respond to Jim?
Well, Jim, I think one of the things to look for, just kind of broadly, is think the constriction of lifestyle that happens as addiction is occurring. That God created us for joy and pleasure and freedom, and addiction just completely strips that away. So I think one of the most pernicious consequences of opioid addiction is it's such a cheap substitute for natural, God-ordained joy and pleasure in life. The euphoria is chemically induced rather than just part of the joy of living and being alive and sharing life with other people. So addiction strips that, and I think that's one of the worst consequences. I think physically, withdrawal from opioids is very painful, but it's very manageable medically. Alcohol is still actually the most dangerous
detox
to detox from, even with medical treatment.
Right.
Right. So I think just the consequence of pleasure being robbed, that it becomes my source of pleasure and joy, and you just contrast that with all of the rest of life that we were designed to experience.
Would you add to that?
Yeah,
Linda?
I'm thinking of, I had a brother-in-law who died of addiction at 49 years old. So we went through this as a family, and you see the irritability, you see the anger outburst, you see the unstable moods, because of the craving and the need for the drug. And you see them doing things that you would never, ever do when you're not on a drug, where you would, he was writing prescriptions and got arrested in front of his 7-year-old child. So those are some pretty damaging consequences. The lying that goes on to just get whatever you need to get, because your brain is so focused on, the brain is basically saying, I need that, I need that, I need that, and you just get so singly focused like you talk about. I think the consequences to the people in your life, not only your own life, but the shame that David talked about, the guilt of doing this, knowing that here I am, I'm in an alley, or I'm this, upstate person in my daytime, but then I'm back here using at night. there's a lot of shame and guilt, and then the negative for the family members is very difficult.
And the triad that tends to go along with shame, the devaluing,
Right.
there's actually a sense of smallness that occurs along with that, and then the hiding.
Yeah.
That trilogy of shame, and you think of that as applied to addiction, and with the prescribed meds, right? There's just this awareness that
That
this
goes
is
all-
just wrong. You
Yeah.
know?
That goes all the way back to the garden. I mean, Adam and
Right.
Eve's first
Bingo.
response was a fear response, a shame response, and
Fear, shame, blame, denial, and
and
concealment.
hiding.
Yep.
And from a spiritual perspective, I think the consequences, what you're talking about, is like people are in bondage.
Exactly.
And the drug, in this case we're talking about opioids, becomes a stronghold. I mean, my definition of a stronghold is anything that has a strong hold of
on
you.
Yeah.
Linda, let me throw you a question. Again, we can dialogue about it, but Laura from New Jersey is asking, has society really changed its views on opioid use? I mean, I guess we could even say the drug culture. We've seen a number of states now legalize the social use of marijuana. Many people still believe it's a gateway substance that may lead to other problems. We live in a more liberal society. Some might think it's no big deal as long as you're not hurting someone else. What do you think? I mean, it is the culture promoting some of the opioid crisis that we're now seeing in our country.
Well, I think there's a huge difference from what we've seen in past years. Like we talked about, when we were talking about addiction, we're thinking of that guy in the alleyway who's from a low-income neighborhood who's sitting there shooting something.
Right.
And now what we're seeing is what we would call respectable people who are highly addicted to prescriptive drugs, who are going into those illegal substances and using heroin and fentanyl and other drugs. So it's shifted in terms of who the people are that are now users. And I was doing my radio show, and my co-host is from West Virginia.
Right.
And he was saying that every week on Facebook, there is a posting of someone who's died in their town of an opiate. And these are just regular people in a city going about their everyday life. So the whole focus has shifted to kind of like the average person who is now at risk, and grandmothers, who you were saying, who are
I
dealing
was
drugs.
astounded.
We had
Yeah.
a call from a grandmother, a guy who said, my grandmother is dealing drugs, what do I do with Granny?
Wow.
This is not the kind of thing that we're thinking about. So
Right.
it is different, and I do get very concerned about the openness to the whole cannabis thing, because I'm thinking, people are driving slow on the highway, we don't really understand how do we even know someone's intoxicated when they're in the car, and their productivity goes down, and there are consequences to these drugs that we're kind of sloughing off, but they do lead to more problems.
And just for clarification, that's different than the medical use of marijuana.
Right.
Which has
and
clear benefits.
But both of these kind of tie in that SAMHSA has some excellent data that they track over the years, and there's the National Survey on Drug Use and Health that they do every year. And one of the most profound graphics that you can watch is, as perceived risk goes down, use goes up, and as perceived risk goes up, use goes down. And so when you think from prevention standpoint, a social message standpoint, approved prescribing, lower risk. All right, we lowered the perceived risk, and guess what?
Right, use went,
Okay, and so we need to take those into account.
You're used to, let's go there for a minute, because our collective fields, whether it's social work or marriage and family therapy or psychology or counseling, the mental health field, we do a great job on the intervention side. Maybe it's not that we don't do a great job. I think it's less attended to the prevention side. So, all of us have been involved in training therapists and training mental health professionals and other people who are going to live in this world. And a lot of what we do is offer treatment and therapy. And you talked about both pharmacological and non-pharm ways to deal with stress and addiction. How do we encourage the counselors and the mental health professionals at all levels out there to think prevention as well? What are some proactive things that we can and should be doing, rather than just trying to put Humpty Dumpty back together again after he falls off the wall? What should we be doing to keep him away from the wall to begin with?
Well, when you look at evidence-based prevention practices and community-wide programs, particularly my message to the church is vital, in that when you look at those aspects of prevention put together that help transform communities, it sounds an awful lot like what the church is supposed to be doing anyway. And so even secular researchers and public policy folks who may really not have a lot of regard for our content beliefs of our faith will still say the evidence is overwhelming that prevention efforts and also recovery efforts, the faith community well lived out is the best thing going. So meaningful parental structure, secure marriage that sets the foundation for the family, meaningful involvement in the community, parental oversight yet with input from the adolescents, meaningful religious and spiritual involvement, right?
Support.
Yeah. All of those things are the best things to do when it comes to prevention, and most of those elements are also important in good recovery at the individual, but also at the community level.
Yeah. And I think there are a lot of things we could change culturally. You know, the whole idea that using drugs is a rite of passage in our universities and our colleges, where it's just unsupervised and things are crazy, and we're hearing on the news that frat parties, people are overdosing and terrible things are happening. I've got a friend who was a cardiologist and it was in the ED, and they would talk about how, just every night there's overdoses and intoxication problems. So this is not okay, because as I said, the best prevention is to never start, to never get to a person. So to be able to have the church be the place where you give yourself your sense of identity, where you understand that you're made in the image of God, where you know that your body is a temple of the Holy Spirit and it should be treated with some respect, and that you should begin then in the churches to have some mentoring in the churches with each other, where people take on, well, how do I deal with the peer pressure? How do I deal with the stress when I just want to escape? And what does the Bible say about pain and suffering and how I'm to deal with that? And I think, have you ever heard a sermon on addiction? I don't know if I've ever heard a pastor even talk about it. I heard a sermon one time on overeating. But in terms of addiction itself,
especially substance addiction, they might talk based a little bit on sexual addiction or pornography, but not substance addiction. So maybe that's another preventative thing that, I mean, we're often talking about the church, all the way from the local church to us being the church, but in church services to have some time allocated in services and or seminars.
Well, that's the thing about this epidemic is the folks are in the pews already.
They're right there.
They're already there.
And they're using.
And let me make a point about the youth, because again, we're trying to target so they never start. I think it's really good for youth programs to think about, how do you have fun? How do you have recreation as a teenager without participating in the drug and alcohol culture? And that is one of the reasons why I love Christian colleges. Now, I know Christian colleges don't have everybody there sober, but the majority, at least, is saying, let's have fun another way. And if you can get them through that developmental period where their brain is getting more developed and they're not using it, and you delay that process,
their identities are developing, lifestyles developing.
You can prevent it.
I've also, you you mentioned about frat parties and stuff. I don't know if you've ever heard of farm parties.
Oh yeah,
or it's called farming with a PH, right? That, and you see it among high school and young adult. The cover charge to go into the party now is go just grab whatever you can find at home in the medicine cabinet or your parents' drawers. You dump it in a kind of a community bowl, and then somewhere, probably after people have been consuming some alcohol, they sort of dare each other to just grab a handful. You don't know. I mean, it could be like your mom's birth control pills with some Oxycontin and how dangerous
anxiety
that can be.
Drug,
so
benzodiazepine on top of that.
I
with the
think
alcohol.
one of the prevention things is to be having parents practice sufficient due diligence to keep their medications, locked up and away from their minor children, because
just
they
to
will
educate
take
them
them
on that, to
Absolutely.
educate them, not
or just
be
out
naive.
of the house, dump them.
Don't save them.
Because part of the challenge with the opioids uniquely is that you can boost the effects. You can have potentiation effects with alcohol.
Correct.
with an opioid, they're relatively, I want to be careful here, they're relatively, they're not that dangerous unto their own, but you start combining them and moving around, and so someone can get a lot of mileage out of 3 or 4 beers if they add one of the one pill of the opioids in there.
And alcohol is a central nervous depressant.
Right.
So.
And so they can put themselves right to sleep permanently and not even know it. Suppress breathing and
Let me read you something. It's a little long. It's from Carrie in New York, who's talking about what they do at their church now. And this might be just a good thing, like maybe some ideas of what churches can do. Their church has welcomed a heroin anonymous group, kind of based on the AA 12-step. And they've invited them to use a meeting space they have weekly. And they decided, hey, we're going to let you do it without any rent charge. We're just going to do it. So they want to come alongside in other ways, both practical and spiritual, to say, do you have any other thoughts or ideas? Their average church age is 65. So you have, especially in rural America, thousands of churches that are small congregations, 100 or less. Maybe you have an older population. What can they do? This church is offering their facility. What else would you throw out there?
Well, I think one of the key roots of any addiction is the lack of meaning, the lack of purpose, maybe the lack of coping with life stress. So if you can help people in any way in a church setting like that, where you can say, in addition to, we're going to help some of your physical needs with giving you a place to meet, maybe fresh meals or hot meals for people, but also then beginning to minister to the spiritual needs of people. Why are they using? Are they empty? I mentioned a few of those. Are they empty? Are they escaping from life problems? Do they need some real help in terms of how do we cope? And a lot of those older people have had a lot of life. And they have a lot of good things that they can offer in terms of, again, that mentoring process, that you can tolerate this with the help of the Lord. And I'm going to introduce you to Jesus, and I'm going to help you understand how Jesus can get you through this crisis, in addition to some good coping skills that you have. So I think, like you said, David, the church is really the place to do the whole package.
Well, and not every church has to offer every service. In other words, even smaller churches can play tremendous roles by supporting efforts in their community, perhaps even hosting community-wide efforts, becoming a host site, so that they don't have to provide direct treatment or whatever, but they support what's going on in their community. That's another way that churches can be, and certainly pray. We pray about this thing.
Well, a lot of addiction is surrounded by people trying to meet legitimate human needs in an illegitimate manner. And it's not like the need that might be feeding that is necessarily sinful or wrong, loneliness or whatever. It's just how they're trying to meet that need is problematic.
Well, I also want to mention too that listen, couple of the government websites are just beautiful repositories for information. And so far as what can the church do? Just get educated.
Be aware.
Get the data. And so SAMHSA.gov, SAMHSA, SAMHSA.gov, NIDA, NIDA.gov, the CDC. Those websites are tremendous sources of Centers for Disease Control and Prevention. They have tremendous information available. And prevention packages already laid out. Excellent research.
I would love to see the church community locally connect. So many times churches are all so concerned about what they're doing. We rarely reach out across the street to our fellow congregations. But I was thinking about this. Remember when the Zika virus was a bit, you had like 2 cases and the whole country is freaking out and trying to mobilize. What do we do? And imagine for a minute that there were as many Zika cases in the country as there were opioid overdose. But yet it's not treated the same way. And so we need to mobilize the church. Here's another great question, I think, a couple of questions. Kyle and Virginia, Priscilla, they're kind of the same thing. What do you do when you have an addicted loved one or a friend? You know they have a problem with it, and maybe you've even talked to them, and they're like, no, There's no response or little response. What do you do? How do you intervene? So this is not so much what might happen in the counseling office, but
Right.
what happens
Right.
at the family level, at the
Right.
social level.
So I can tell you the worst thing is to enable the process. And people who are addicted and addicts are very good at manipulating and lying and trying to convince you to do things because, again, their brain is being affected by the substances that they're craving and needing. So you have to be very careful to set those tight boundaries. And we've all heard about interventions where you get together as a family and you intervene as a family and you stay on message that this is a problem. This is something you need help with, and we are not going to sit here and watch you die. We're going to do what we can to get you into a treatment program and help. And I think it's tough for families to take that position.
Right.
And a lot of times they'll give in to the messages because they're so caring and concerned.
Yeah.
But you got to have some toughness with
I would
this.
say revisit sort of the original conceptualizations of tough love, not what it's turned into.
Right.
Tough love was never about being tough with them.
Right.
It was first and foremost about being tough with self.
Right.
Like I have to confront my fear of what will happen if I change. You see what I'm saying?
Yeah,
so,
yeah.
so that the boundary really is about you,
Yeah.
right? And I just say, look, lead the way in terms of what deep personal change looks like.
Yeah.
You know, but become an exemplar for that process of deep personal change. And along the way, the boundaries will get set, but
Right.
not by being hard and harsh out there.
Right.
It's by being a whole individual who is committed to
Right.
living a righteous life.
Right.
And yeah.
You know, I guess dealing with an angry family member or an angry friend because you confronted them, at least you have the opportunity to work on it, but not with a dead family member.
Right,
Not
right.
with a dead friend.
Right. So
Right.
you have
know.
to speak the truth in love. And so, the message that we continuously said, obviously didn't get heard, but was that I cannot watch you die if I love you and care about you. And this is so difficult. And then we had other family members who were not giving that message and were enabling. So I would say families need to get together. And if you have a loved one and you continue to give that message of, I love you, I care about you, it's very hard to watch you self-destruct. But the addict then wants to get away from that because,
Right.
again, it's escape avoidance, right, of pain. So if I'm confronting you, I'm causing you pain
Right.
there. And that's one of the
Sure.
reasons why you use to begin with. So you have to stay connected.
Right.
You have to somehow keep giving the message, I care about you, I love you, but it's hard for me to watch you do this. You need to get some help.
And that's the importance of having good alternatives readily available to offer. You know what I mean?
Right.
That okay, it's not just this to nothing.
Yeah.
It's
Yeah.
this to recovery and wholeness.
That's right.
Yeah.
Right.
So we are down to our last couple of minutes. So I'm going to take Amanda's question from Oklahoma, and Linda, I'll pinch it to you first, and then you, David, if you take half a minute or so. And if you could pick one thing that's difficult, but if you could pick one thing that you think would be the most beneficial to offer those struggling with an opioid addiction, what would it be? So kind of like your closing thought. Listen, what would your takeaway be to those tuned in today?
I know it's tough. It's really tough to get off an addiction. We know that when we're talking about relapse rates, we're talking about multiple times, often with addiction. But I'm not going to guess this is going to be your same answer, David, but it's really the message of hope that this is not something, yes, I got to go first. This is not something that cannot be overcome.
Right.
And I love Darryl Strawberry, the baseball player, is a friend of mine, and the name of his new book is Don't Give Up on Me. And there was one person in his life who never gave up on him, and he is now clean and sober for, I think it's 12 or 14 years, I don't remember, but that's a long time.
Yeah.
So this is a guy who was using massively, was hooked on opioids, on amphetamines, on alcohol, and all kinds of stuff. And here he is, he's living a life for God, he's strong, he's clean, he's sober, and somebody said, I'm not going to give up on you. So hope is one of those things that is so important.
Yeah. David, what would you add to that conversation?
I certainly second that. She took it, but that's okay. It's all available for all of us, actually. Faith, hope, and love. And the greatest of these is love, the agape love that hangs in there based on the worth of the individual, the willful choice to submit oneself for the betterment of somebody else. And I think then to the willingness. Jesus despised the shame of the cross. He shamed the shame of the cross. And I think we have to be willing to enter into shame and be able to sit with others in their shame. And it's an uncomfortable place to be, but it's probably a Christ-like place to be. And that hope of what occurs when people connect that way.
Yeah, that's great.
Yeah.
Well, our time is up, so we want to thank you for tuning in. I want to, on behalf of the AACC, again, thank our guests, our presenters, Dr. Linda Mintle, Dr. David Jenkins, as we've been talking about opioid addiction and addiction. Just a couple of things I just want to remind you. AACC has some great resources. There's a quick reference guide on addiction and recovery that just may be a great little on your desk reference for you if you're working with people who wrestle with addiction. And then also want to remind you about AACC's Mega National Conference coming up next September, the 27th, 29th in Dallas, Texas. There will be a whole track on addiction. So thank you for being part of this presentation, being part of the family. We just want to say God bless you for all the work that you're doing with those who are hurting and broken. Take care.